Go, Dr. McAllister. Do you have a comment?
Yeah, I do. A couple of things. First, with regards to iron deficiency anemia, serum ferritin is definitely the thing to test because that's the stored iron. Studies have shown that this subclinical anemia can be brought out by exercise. So a question to ask the patients would be, if you exercise, do you feel very tired or wasted after your workout? And every time I've asked a patient that and they said yes, because I was suspecting iron deficiency, it did pan out that the serum ferritin was low. So that's a good question to ask your patients if they are the type to exercise. The other thing is regarding dopamine. There are some herbal remedies that have naturally occurring L-dopa in it. The first would be fava beans. And the only thing you have to be cautious of is certain patients with blood dyscrasias should not have fava beans. But otherwise, you can recommend that to your restless leg patients. The other,
but Dr. McAllister,
yeah,
I hate fava beans.
Okay, you can get a supplement of the fava bean extract.
I'll be done.
The other thing is mucuna is an herb that also has naturally occurring L-dopa in it. I use neuroscience. They used to use the mucuna, but now they're using the fava bean extract in their formula. But if you want to build up the dopamine level, you can go that route. The other route would also be the amino acid tyrosine, which is a precursor for dopamine. Of course, tyrosine is also used for thyroid hormones, so you don't know which direction that amino acid is going to go if you supplement.
Well, Rich, put that together in a post for the Google group, but also be aware that I think the studies that I've looked at, the tyrosine has not been proven effective for sleep and stuff like that. I mean, after they, even though it seems to work after you eat the turkey dinner, they've done a couple of studies, and I haven't seen that pan out really.
Well, that would be in the turkey. That would be tryptophan.
Tryptophan, got it.
Yeah, the tyrosine. Tyrosine is possibly going to go toward making thyroid hormone more so than dopamine. So you just don't know which way it's going to go. So it's something you can try, but the best way to go would be with the formulations that have natural occurring L-dopa in it. But you should, if you're going to do that, monitor urinary neurotransmitters so you can see, kind of gauge where your dopamine is. Because if the dopamine goes too high, you will get those
crazy legs.
Yeah, well, actually, you can get a lot of crazy things happening to your behavior.
Thanks for that information, and that's why you see it with the Requip and the Mirapex. That's why you see them going down. Thanks for those comments, Richard, as always.
Okay.
We look forward to that post on the Google group. Now, Rich is one of the guys that talked to me about this vitamin D deficiency in falls. Well, it was vitamin D deficiency in neuropathy. And, you know, I took it to another level of looking at it and reading the literature and was completely blown away by how much literature there is out there on the effects of vitamin D on falls. And falls reportedly occur, and this is the next blitz, guys. The next blitz that we're doing next month is balance. This is the first time we're actually putting out our ads for balance patients. And we're going to use the information and this new information to get on it. And we're going to do the blitz just like we did before. We're going to do another new talk on balance here in the studio, record it for everybody to have. So it's great. I mean, it's just the way to go. We're having such a good time with these people. Okay, 30% per year of those over 65 or older have a fall. And 40 to 50% of those 80 years or older. So about half of the people who are over 65 are going to be falling. Falls constitute the largest single cause of injury mortality in elderly individuals. An independent determination of functional decline leading to 40% of all nursing home admissions and a substantial societal cost. Fellas, this is the paper. This paper right here, you can do anything you want. You can say this to your patients. When you say that to them, they get tears in their eyes. Because of the increased proportion of older patients, okay, think about this. The patients that are 55 now in 10 years are going to be, the boomer market is this market, and we've got to tailor our marketing to these people. Annual cost from falls reported to be $20 billion, and it's going to just rise. And that's what we're going to do too. So, disorders that produce or aggravate low vitamin D status. Osteoporosis. Look at that. How many of your patients have osteopenia? How many patients have osteoarthritis? Disease, hypertension, diabetes. The strength of the evidence is these aggravate low vitamin D status. Now, vitamin D supplementation reduces the risk of falls among ambulatory and institutionalized older patients by more than 20%, with benefits clearly from vitamin D. And I know that we're trying to come up with the proper amount of vitamin D, and probably Dr. McAllister will help us out with that. But this is from the New England Journal of Medicine, vitamin D deficiency. Approximately 33% of women between 60 and 70, and 66% of those have osteoporosis. It's estimated that 47% of women and 22% of men over 50 will sustain an osteoporotic fracture in their lifetime. Among 3,000 women giving 1,200 milligrams and 800 IUs of vitamin D3 daily for 3 years reduced the risk of hip fracture by 43% and non-vertebral fractures by 32%. Vitamin D deficiency causes muscle weakness and skeletal muscles, vitamin D receptors, and they require vitamin D for maximum function. So when you're working on your balance patients, you want to give them vitamin D. Okay? In a randomized controlled trial conducted over 5 months, nursing home residents given 800 IUs of D2 per day had a 72% reduction in falls. That's pretty good. Patients with mild or moderate hepatic failure and intestinal fat malabsorption, as well as patients taking, what's that? Anticonvulsant medications, Neurontin, gabapentin, all that stuff, the Lyrica, they give vitamin D problems, and you have to give them more vitamin D. An evidence-based review on vitamin D is a hormone precursor. D2 is present in plants and fish. D3 is sensitized by the skin. And who gets skin anymore? Everybody's afraid. And this vitamin D deficiency is caused mostly by these people using sunscreen. Vitamin D or exposing them to sun. But the sun is between 10 and 2. You guys don't have any sun in New Jersey. You kidding me? Vitamin D3 can be manufactured by the skin, but UVBs are only during midday or higher and do not penetrate the clouds. So you need this stuff. A recent study in animals and humans has suggested that vitamin D may play a role in the homeostasis of glucose metabolism in patients with diabetes 1 and 2. An important factor in fall status among elderly patients. Vitamin D supplementation reduces the risk. It improves their muscle function. A dose of 800 IUs significantly reduces the falls. Chronic pain. Because of the important role of vitamin D plays in bone, we have questions whether vitamin D deficiency may also correlate with chronic pain syndromes. Several case series of observational studies suggest that vitamin D inadequacy may present a source of nociception and impaired neuromuscular functioning among patients with chronic pain. How about that? So our nutritional supplement pamphlet now that we give out, nutritional suggestions, has vitamin D in there at a big time. So here's a new one. 2010, fellas. Simvastatin does not affect vitamin D status, but low vitamin D status levels are associated with bad cholesterol. Okay, so what they're saying is that while they know that statin drugs inhibit coenzyme Q, okay, recent studies suggest that statins may improve vitamin D status. Is that so? Well, this is one thing that they talk about, but then they look at here, low serum vitamin D levels are associated with reversible myositis myalgia in statin-treated patients. So something is going on there with the way the D vitamins, the calcium and vitamin D is working with the statin patients, and I didn't have time to finish it up, but again, this is January 2009. Okay, so when they were given their vitamin D, their muscle pain from the statins got better. We speculate that symptomatic myalgia in statin-treated patients with concurrent vitamin D deficiencies may reflect the reversible interaction between vitamin D deficiency and statins on skeletal muscle. So again, the statins are in the forefront, but the vitamin D is in front. And this is a letter that Statin Therapy, Muscle Function, and Vitamins. He says that statin use may exacerbate muscular performance declines and falls risk associated with aging without concomitant decrease in muscle mass. So something's going on with these people. Since it's all coming into the same thing, I mean, if you give them statin use and it reduces their vitamin D, it's not going to help them. Statin use in muscle function and risk of falls in older people. I think we just did this one, right? Statin therapy, muscle blah. I think we already did that. Intervention for preventing falls in older people. Research is needed to confirm the extent, but what they're saying is vitamin D supplementation are very effective. Improves neuromuscular function in older people who fall. Okay, key points. Impaired function is related to increased risk of falls and fractures. Vitamin D supplementation has beneficial effects on functional performance, balance, and reaction times, but not just on muscle strength. Really depends on what they do, maybe. Coordination rather than muscle strength per se. Urgent need to recommend an intake that is effective of vitamin D. And one I'm just going to break through, it says the optimal amounts are closer to 1,000 IUs daily. Even though some people are saying, and I think if you look at that post that Dr. Burke put in, he put in 10,000 IUs, 5,000 IUs. So let's take a look at this. I'm sure we're going to have some questions on this, some comments. Any comments? Anybody want to comment on this, of vitamin D? Yes? Let's take a look here. We can also throw up any other questions. Yes, Dr. McAllister.
How you doing again, Joe?
Of course.
A couple of things about vitamin D. Are you getting a little static? I'm getting a little static on this end.
I'm good.
Okay. All right. It's very simple to just send your patient to the lab for the vitamin D level test. The only thing I would caution is that there are a couple of different methods of determining vitamin D. It's LabCorp would be the lab that I would prefer, because they use the method that is used in most of the research that determines the optimal levels of vitamin D. Quest Lab uses an entirely different method, and there, when you get a vitamin D reading from Quest, it's going to be as much as 3 times higher than if the test done the other way that LabCorp uses would read. So just keep that in mind. The other thing is you can very safely put just about anyone on 2,000 units of vitamin D. I'm using 5,000 units per day. I'm still a little leery about putting people on 10,000 units a day, especially if you're not going to monitor them with lab tests. Although much of the research seems to indicate that the fears of vitamin D overdose are highly exaggerated, there are a number of cases where they've used 50,000 units for 6 months or more without any problems. But I would, if you want to be conservative, I would just stick with either 2,000 units a day or make sure you're monitoring the vitamin D lab every 3 months, just to make sure you're getting them up to the target range. And the target range, the optimal would be around somewhere between 50 and 60 units. So I just wanted to toss that out. And I had another comment, but it kind of escaped my mind. So,
That's fine, Doc. Well, I really, thanks again for those comments, and you know that this is big time, and so anywhere between, your comments were about 2,000 IUs is fine. I mean, I'm always on the conservative side. I'm going to stick closer to 800 or 1,000 and monitor their progress and see what happens. But I think it's great that it's something that we can do and go get the blood work and actually show these things are screwed up. The iron is one thing we can look at, and the calcium is another thing we can look at. Let's go around the room here and see what people got to say. Dr. Jeff, are you on the line? Dr. James? Got to get a microphone. How's Dr. Temple doing? No mic today, you said, right? Yeah, he's in the other office. Dr. Heiler, you available? No? Riggleman, did you get a mic yet? No. Any comments, Dr. Benson? Any comments? Well, I don't see nobody else has got a mic, so we're used up our time. You can see here, if you look here, that we've had a number more of these to go over with. I'm very glad we had a chance to go over this stuff. I want to show you just in the last brief seconds this Friedrich's variant, because you can get messed up with this pretty easily with these patients. This lady came in, and when I was doing my exam, I couldn't really see anything big time in her feet, really. And she had neuropathy, and I was yelling at her about being diabetic. And I said, well, let me see your tongue. And you can see, I'm trying to get a picture here for you. I think this is the best one. You can see the little fissures in here. Okay, so it's not that great. There's fissures here, 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 and here, a little bit back there, but nothing too great. And this was her foot when it was sitting on the ground. Okay, it's a little bit longer. There's no hammer toes. But when there she's just sitting there, her hammer toes over here, but nothing that would make you look like a Friedrich's foot until she lifted it up. And there you have it. She doesn't have that super high arch, but that's one of the things that kind of threw me. So she has a genetic variant on her neuropathy, but it was pretty weird that you couldn't really see it at all when she was there with her foot down, and we've seen that before, so I wanted to pass that along. If you have any questions on the Friedrichs, go online and get that video that I made. Okay, so I really think this was a great webinar. I got a lot out of it. We did some recording here, and hopefully it'll all work out great. We'll upload this as soon as it's done for the rest of the guys. See you guys next month. We'll also have the, remember the Primo's coming up on February 13th. And get your Blitz ordered, fellas. Okay, Brian. We'll see you guys later.